So I'm going to talk in the next 10 minutes about secondary hypertension and a stepwise approach. So we all spoke about primary essential hypertension, which is 95% of the hypertensive population, where we have multiple genetic and environmental factors, but no specific cause. Whereas in secondary hypertension, we have an identifiable specific cause. It forms 5 to 7% of the hypertensive cases which we see. There are many reasons for the secondary hypertension, which we have to look for in all the primary hypertensives which we diagnose. So the most common thing is drug abuse or some kind of side effects of the drugs. Renal disease, with Dr. Bharat Shah, we know that renal parenchymal disease, polycystic, chronic glomerulonephritis, chronic interstitial nephritis, diabetic nephropathy, obstructive kidney disease, renovascular disease, renin-producing tumor, primary sodium retention. In vascular causes, coarctation of aorta. In neurological causes, increased intracranial pressure, porphyria, familial dysautonomia, lead poisoning, Guillain-Barré syndrome. In endocrine, we have thyroid disorders, adrenal disorders, Cushing's, congenital adrenal hyperplasia, primary aldosteronism, Pheochromocytoma, hypercalcemia and hyperparathyroidism, carcinoid tumors, extraadrenal and exogenous hormones of estrogens, androcorticoids, sympathomimetics, MAO inhibitors, and so on. Pregnancy-induced hypertension also is secondary hypertension, and in certain stressful situations, we do get secondary hypertension. So these are the causes, but the mechanisms of secondary hypertension are almost the same, except in few conditions where there are specific hormones which give rise to the hypertension. So increased vascular tone, sodium and water retention, abnormal sympathetic activation, abnormal RAS activation, and endothelial nitrous oxide mismatch. So these are the basic mechanisms. And amongst that 5 to 7 causes, depending upon the age group, depending upon geographical distribution, you will find there are different incidences or prevalence of secondary hypertension. Of course, renal hypertension forms the most common cause, parenchymal or renovascular, endocrine, cons, Cushing, pheochromocytoma also, and drug-induced, specifically oral pills also form that. Now, according to the age group also, you can divide this in children from up to 11 years of age. Most common would be renal parenchymal and coarctation of aorta. And in renal parenchymal, maybe congenital polycystic kidneys or glomerulonephritis would be there. Adolescent, 12 to 18 years, renal parenchymal and coarctation of aorta. Young adults, thyroid dysfunction, fibromuscular dysplasia, especially in females. Renal parenchymal disease also one has to rule out. In middle-aged, hyperaldosteronism, thyroid dysfunction, obstructive sleep apnea in obese individuals, Cushing syndrome, and pheochromocytoma. And in older adults, of course, atherosclerotic renal artery stenosis, CKD patients, diabetic nephropathy, and hypothyroidism. This is the age group. Now, what are the general clinical characteristics when you suspect that this could be secondary hypertension? If you have an early age, I mean in early onset of hypertension, very young in age, especially less than 18 years of age, 18 to 29 in patients, and where there are no obvious risk factors, family history or obesity, and in increased blood pressure in prepubertal children. So this age group, an early age group should suspect when there are no other risk factors. Resistant hypertension despite 3 drugs, severe hypertension or hypertensive emergencies, or hypertension with gross secondary target organ damage, and a sudden rise in blood pressure, especially in the elderly people when they are stable, but there is a sudden rise. Or as in sleep apnea syndrome, you will find that the dipping patterns have changed. So these are the basic features. Like we all know pheochromocytoma from our student days, we remember 4 P's: paroxysmal hypertension, palpitations, headaches, diaphoresis, tachycardia, and diagnosis by the urinary catechol metabolites of VMAs and metanephrines. Plasma nowadays with plasma-free metanephrines also. Hypothyroidism, fatigue, weight loss, hair loss, diastolic hypertension, more, and muscle weakness. The hyperthyroidism by heat tolerance, weight loss, palpitations, and more of systolic hypertension with tachycardia. Hyperparathyroidism, kidney stones, osteoporosis, depression, lethargy, muscle weakness, and we diagnose that by serum calcium, parathyroid hormone levels, and so on. Acromegaly, increase in growth hormone levels, more of enlargements of head, feet, hands and feet, tongue, headaches, visual problems, fatigue, and so on. So coarctation of aorta, classical in children and young adults. We see there is a mismatch between the femoral and the brachial pulses, and confirmed on 2D echocardiography and CT scan. Cushing's syndrome, weight gain, fatigue, weakness, hirsutism, amenorrhea, moon phases. This could be either iatrogenic or could be spontaneous. And the test to be done is dexamethasone suppression test. So these are the things. And of course, obstructive sleep apnea with history of snoring and doing a sleep study. Aldosteronism will come to, and renovascular disease will come to. Now, what are the drugs? NSAIDs, oral pills, steroids, sympathomimetics, cyclosporin or tacrolimus, erythropoietin, ephedra, mohang, bitter orange, cocaine or amphetamines, and excess of alcohol. So these are the secondary, these are the drug-induced causes which one has to look for. This is again a flow chart depending upon the age group and depending upon the cause which you suspect. You try and go ahead with the investigations and confirm the diagnosis. So renal causes, two forms, parenchymal and renovascular. Amongst the parenchymal, chronic glomerulonephritis, chronic interstitial nephritis, pyelonephritis, nephrocalcinosis, neoplasm, glomerulosclerosis, analgesic nephropathy, polycystic kidney disease, gout with renal failure, and obstructive nephropathy. So this could be various causes in different age groups, and one has to suspect this in all hypertensive, primary hypertensive patients, and do a screening of the renal parameters. So renovascular, commonest cause is atherosclerosis in the middle and the elderly age group. Takayusi's arthritis, also one of the common causes in India. Fibromuscular dysplasia, other causes like aortic renal dissection, thrombotic or cholesterol emboli in the very elderly octogenarians, post-traumatic, post-transplant stenosis, and post-radiation also would be causes. So we clinically, we look for a bruit, mainly diastolic renal bruit is more specific than the systolic renal bruit. You look for microalbuminuria, macroalbuminuria, and you do a color Doppler ultrasound, CT angiography, MR angiography, and a 99 technetium DTPA renal scan test also would help you in this diagnosis. Of course, the confirmatory test will depend upon what non-invasive parameters you have, but finally we look for a conventional angiography, which is the gold standard to detect renovascular. Captopril screening test also is one of the tests, but less commonly done nowadays, with many more other non-invasive tests being there available. Classic case of renal artery stenosis. This is fibromuscular dysplasia, if you see here. So the classic beaded appearance of fibromuscular dysplasia. Okay, so now these are the endocrine causes. Now adrenal dependent causes, Piochromocytoma and sympathetic paraganglioma, primary aldosteronism, then hyperdeoxycorticosteronism, could be congenital or could be because of tumor, and Cushing syndrome, then apparent mineralocorticoid excess. So there are many such causes, genetic and acquired, following drugs also. Cushing syndrome, as I said, parathyroid dependent causes, hyperparathyroidism, pituitary causes, acromegaly and Cushing syndrome, secondary hyperaldosteronism, renovascular hypertension, thyroid disorders, and obstructive sleep apnea. So pheochromocytoma, another one of the common things which we should look for. Yeah, okay. So it is episodic hypertension. There could be postural fall, pallor, throbbing headache, palpitation, and perspiration. So perspiration, palpitation, postural fall, and pallor, 4 P's of that. We look for screening like plasma and urinary metanephrines and VMA levels. And then, of course, you can do PET CT scan and to confirm the diagnosis. Tumor localization is done by CT scan and MRI of the abdomen, or MIBG labeled I-131, which you will hear from Dr. Mahapatra, all these tests. And as far as the preoperative preparation, oral phenoxybenzamine 10 milligram once daily. If you don't have that, oral alpha blockers followed by beta blockers could be the drugs. Primary aldosteronism, another important thing which we should always look for. So when you screen your primary hypertension patient, please look for serum electrolytes always, and just don't do serum urea, creatinine levels. Look for hypokalemia, look for persistent hypokalemia with metabolic alkalosis. If you get this, then you should suspect, and if it is persistent, you should suspect that this could be one of the causes. So, and how do you investigate? You do the plasma aldosterone to plasma renin activity, which could, if more than 20 to 25 is highly suspicious. And then you can do, of course, the other confirmatory test, the response to oral sodium chloride load, fludrocortisone or captopril test. You can do nuclear scan. And the most commonest way this is diagnosed is by the CT abdomen. CT abdomen is being done for various other causes, and the radiologist picks up the adrenal enlargement, and then you have to investigate these patients, whether they are compensatory, physiological, or whether they are producing hormones, and then we do this test. So the treatment is surgical removal, and we start spironolactone to this patient, which minimizes the hypoaldosteronism and restores potassium level. Cushing syndrome, the classic sudden weight gain, truncal obesity, moon phases, and hypertension is present in 80% of these patients. The 24-hour urine-free cortisol level is more sensitive and specific. And then you do the low-dose dexamethasone suppression test. Give 1 milligram dexa at 11 p.m. and draw a sample of blood in the morning for cortisol measurement. If more than 100 nanomoles, it is positive. And then followed by CT and MRI of the head and the chest to look for pituitary or ectopic or the abdomen thing. So these are the various surgical. I will not go into this. Coarctation of aorta will be discussed by the vascular people. There is a special talk on that. But if you see here, this is the coarct in children, congenital. Sometimes in adults, it could be post-radiotherapy also. Pregnancy and hypertension is a separate topic by itself, but enough to know that pregnancy-induced hypertension is also one of the secondary causes, especially during pregnancy. Pills, thyroid disorders, stress-induced. I will not speak much about that. And finally, the initial assessment of a hypertensive patient should include a complete history and physical examination to confirm the diagnosis of hypertension. And before you label this as primary or essential hypertension, secondary hypertension has to be ruled out, especially including the onset at a young age, less than 20, abrupt onset of hypertension, blood pressure, difficulty in controlling them, requiring more drugs, more blood pressure, more target organ damage. If all these are there, then one should definitely suspect and rule out secondary hypertension. And the investigation of choice would be depending upon what etiology you are looking for, whether it is renal or whether it is endocrine or whether it is obstructive sleep apnea and so on. So with that, I would end my lecture. Thank you very much.